Welcome back to the Deep Dive. Today, we are wrestling with a subject that is, it's absolutely foundational to modern health, but it's often hidden behind some pretty dense medical language.
It really is.
We're talking about hyperlipidemia. So if you've ever wondered why your doctor is so focused on your cholesterol and your triglycerides, that's it. That's hyperlipidemia, the official term for abnormally high levels of lipids.
Right. And it's usually, characterized by high LDL, high triglycerides, or that frustratingly low HDL.
Exactly.
But it's so much more than just a numbers game. I mean, we're talking about the body's entire system for transporting fat and energy. It goes from the food you eat right down to the genetic switches inside your liver cells.
And that's our mission for today. We're doing a deep dive into that whole transport system to understand how it can go wrong and, more importantly, how 6 major classes of medications interrupt that process.
And they each target a really specific vulnerability in the pathway.
It feels like you have to know the plumbing before you can understand the repair kit. So let's start there. Let's unpack the system. How do we even absorb fat in the first place?
Okay, so it all begins in the intestine. The fats you eat, cholesterol and free fatty acids, or FFAs, they aren't water soluble, so they need help.
They need a carrier.
They need a carrier. The liver produces bile acids, which they bind to those fats and form these tiny little structures called micelles. And these micelles, they're the packaging that allows the fats to finally be absorbed.
And once they're across that wall, they get immediately repackaged into the body's, delivery vehicles. And the first ones are huge.
Oh, they're enormous. They're the largest of the lipoproteins, the chylomicrons. You can think of them as these massive oil-laden barges.
Okay, I like that.
They're super rich in triglycerides, TGs, and cholesterol. And because they're so big, they actually enter the lymphatic system first before they even get to your main blood circulation.
And that's where things really start to happen. As these barges, the chylomicrons, are cruising along, they hit a kind of an enzymatic checkpoint.
That's the one. That checkpoint is the enzyme lipoprotein lipase, or LPL. LPL is located on the surface of tissues outside the liver, so primarily your fat tissue and your skeletal muscle.
And its job is?
Its job is key. It breaks down the triglycerides carried by chylomicrons, and another one called VLDL. It breaks them down into free fatty acids.
So LPL is basically pulling the fuel out of the barges.
Exactly. So your muscle can burn it for energy or your fat cells can store it.
Right.
And as LPL strips off those triglycerides, the chylomicron shrinks. It becomes this cholesterol-heavy remnant that gets recycled back to the liver. And at the same time, the liver's making its own delivery vehicle, VLDL, which is also TG-heavy, and it undergoes the exact same process.
And that VLDL, once it's been stripped of most of its triglycerides, that's what becomes the infamous low-density lipoprotein, LDL.
The famous one. LDL is mostly cholesterol. And look, we have to be clear, you absolutely need LDL.
Yeah, it's not all bad.
Not at all. It's essential for making steroid hormones in your adrenal glands, your gonads. It's a necessary delivery service.
It's when that delivery service starts running rampant that the trouble begins.
Yes. If the system gets saturated, excess LDL starts to burrow into your vessel walls. And there, your immune cells, macrophages, they detect it and try to clean it up by basically gorging on the cholesterol.
And when they do that, they transform into
Foam cells.
Foam cells.
And those foam cells are the biological starting point for the plaques, the atherosclerotic plaques that harden and narrow your arteries.
Okay, so if LDL is the problem, where does the cleanup crew fit in? I'm talking about HDL, high-density lipoprotein.
HDL is the unsung hero here. It's the reverse cholesterol transport system. Its specific mission is to scavenge. It travels to those vessel walls, pulls excess cholesterol and fat out of the foam cells, and brings it all back to the liver.
For disposal.
For disposal or recycling.
Yeah.
And that vital action is why high levels of HDL are considered protective.
So we've got the delivery trucks, the stripping enzyme, the cleanup crew. What happens when it all goes wrong, when LDL or triglycerides are just chronically high? What are the clinical consequences?
Well, that's the real issue, and it goes beyond just the future threat of heart disease. Sometimes you can actually see it.
Really?
Yeah, we see literal fat deposits, visible clues like xanthomas in the skin or xanthelasma around the eyes. We also see fat deposited in organs, which leads to hepatic steatosis, fatty liver disease.
It's amazing that an internal problem can leave like a calling card on the outside.
It is. But if we're talking about acute danger, the critical risk, especially for patients with really high triglycerides, is pancreatitis.
Oh, wow.
If TGs spike over 500 or especially 1,000, the sheer volume of fat causes this acute, life-threatening inflammation of the pancreas, and that is an emergency.
And then, of course, there's the big one, the long-term threat, atherosclerotic cardiovascular disease, ASCVD.
That's the endgame of chronic plaque buildup. The plaques reduce blood flow perfusion, and they starve tissues of oxygen downstream.
So in the brain, that's a stroke.
A TIA or a full stroke, a CVA. In the heart, that's coronary artery disease, maybe a heart attack. And in the limbs, it's peripheral artery disease.
It's a systemic problem.
Yeah.
And while some of it is genetic, a lot of it is acquired through things like diabetes or obesity.
Yeah.
So knowing all that, how do we fight back? Let's start with the undisputed first line of defense, the statins.
Statins are the foundation. They're the HMG-CoA reductase inhibitors, and their mechanism is just a beautiful piece of pharmaceutical design.
And this is where it gets really cool, because they don't block the absorption of fat, they interrupt the making of cholesterol inside the liver.
Exactly. So cholesterol synthesis in the liver, it follows a chain.
Yeah.
Acetyl-CoA becomes HMG-CoA, which becomes mevalonate, which then leads to cholesterol. Statins block the enzyme HMG-CoA reductase that does that crucial conversion.
It breaks the chain.
It breaks a chain, which directly cuts down how much cholesterol the liver can make.
But the real therapeutic magic isn't just that. It's the liver's reaction, right? The rebound effect.
That is the key takeaway. When the liver senses its internal cholesterol stores are dropping because of the statin, it thinks it's starving. So its genetic machinery kicks in and aggressively increases the number of LDL receptors on the cell surface.
So it's like throwing open the gates and casting out huge nets.
A powerful set of nets. The liver starts furiously scavenging massive amounts of LDL cholesterol right out of your bloodstream to try and replenish its stores. And that dual action is why statins cause such a profound reduction in LDL.
We all know the names atorvastatin, rosuvastatin, and the intensity really matters, with high intensity being, say, rosuvastatin over 20 milligrams. But powerful drugs,
Yeah.
powerful side effects. What do we watch for?
The main concern patients report is muscle injury. It can range from just general soreness, myopathy, to a severe breakdown called rhabdomyolysis. And the theory behind it is fascinating.
It has to do with coenzyme Q, right?
It does. Statins deplete coenzyme Q, or CoQ, in skeletal muscle. And CoQ is absolutely vital for the electron transport chain, which generates ATP cellular energy.
So less CoQ means less energy for the muscle cells.
Exactly, which leads to injury and weakness. It's a really key metabolic connection to remember.
And it's worth pointing out that not all statins have the same risk. I think the sources mentioned pravastatin and fluvastatin are a bit easier on the muscles.
That's correct. That slight chemical difference can sometimes be the answer for a patient who is really struggling with muscle pain. We also have to watch the liver, of course, with liver function tests, LFTs.
Okay, so if statins are the foundation, what do we add when we need to go after those high triglycerides? Let's talk fibrates, like fianofibrate.
Fibrates are the best drugs we have for aggressively lowering triglycerides. They also give you a nice little boost in HDL.
And how do they work?
They work by enhancing the activity of that critical enzyme we mentioned earlier, lipoprotein lipase, LPL.
So instead of blocking the factory, they're turbocharging the removal crew out in the muscle and fat.
That's a perfect way to put it. By stimulating LPL, they just speed up the breakdown of TGs from VLDLs and chylomicrons, clearing fat from the circulation. Now, for side effects, you have to know two major ones. First, the risk of gallstones.
That seems like a random leap. Fat metabolism to gallstones. What's the link?
It's a classic indirect consequence. Fibrates inhibit an enzyme called 7-alpha hydroxylase. That enzyme is essential for making bile acids. So when you have less bile acid relative to the amount of cholesterol in the bile,
The cholesterol precipitates out. It forms stones.
it forms stones, exactly.
Oh, wow. And the other major caution is combining them with statins.
Yes, this is a big one. Fibrates can inhibit the body's CYP450 enzyme system, which is what the liver uses to clear many drugs, including most statins. So if you inhibit the clearing system, the statin concentration in your blood skyrockets.
Increasing the risk for that severe muscle breakdown, rhabdo.
A very dangerous drug interaction.
All right, next up, niacin, or nicotinic acid. This one has a reputation for its effect on the good cholesterol.
It does. Niacin is the most profound drug we have for increasing HDL. It also drops TGs and LDL. It's a triple threat, but it's notorious for side effects.
How does it manage to do all three?
So for triglycerides, it inhibits an enzyme called hormone-sensitive lipase, HSL, in your fat tissue. By blocking that, Fewer free fatty acids get released back to the liver, so the liver has fewer building blocks to make VLDL and LDL.
Less raw material coming in, and the HDL boost.
For HDL, it actually inhibits the liver's reuptake and breakdown of HDL molecules, so it just keeps the plaque cleaners in circulation longer, letting them do their job more effectively.
But the side effect everyone knows is that intense flushing and itchiness.
The pruritus, yeah, that's a prostaglandin problem. Niacin stimulates a pathway that releases prostaglandins, which are potent vasodilators. That's what causes the intense heat.
But there's a simple fix for that, isn't there?
A really neat trick. You take a small dose of aspirin or ibuprofen before the niacin dose to block the production of those prostaglandins. It works remarkably well.
You also have to watch out for gout and diabetes risk with niacin.
Absolutely. It can cause hyperuricemia, so a risk for gout. And more importantly, it can cause hyperglycemia. It can induce insulin resistance, which makes it a really tough choice for a patient with diabetes.
Okay, let's pivot back to LDL reduction with some more advanced tools. First up, ezetimibe.
Ezetimibe is a great add-on. It's very effective at lowering LDL, and it's usually really well tolerated. Its mechanism is simple. It directly blocks the absorption of cholesterol across the wall of your GI tract.
And if less cholesterol is absorbed, we get that same rebound effect in the liver again, right?
Precisely. Less cholesterol gets back to the liver thinks there's a shortage, and boom, it upregulates its LDL receptors to pull more cholesterol out of the blood. It's a fantastic second-line option.
Next, the bile acid sequestrants, or BAS, like cholestyramine. Their mechanism is even more physical.
They're like little sponges. They are positively charged molecules that bind to the negatively charged bile acids in your intestine. This stops them from being recycled, so they just get eliminated.
So the liver has to panic and make all new bile acids from scratch.
It does. And to do that, it has to pull from its own internal cholesterol stores. And just like with statins and ezetimibe, that cholesterol drop forces the upregulation of LDL receptors, pulling LDL from the blood.
It sounds logical, but there's a huge warning label on this one.
A critical one. BAS can actually raise triglycerides. By forcing the body to mobilize lipids to make new bile acids, it can sometimes increase TG synthesis as a side effect. So you never, ever use it in a patient who already has high triglycerides.
And being a sponge, it binds to other things too.
Correct. It can block the absorption of fat-soluble vitamins A, D, E, and K, and really importantly, it can bind to drugs like digoxin, warfarin, and levothyroxine. You have to tell patients to space those doses hours apart.
Finally, we get to the new generation. The PCSK9 inhibitors evolocumab.
These are the heavy hitters. They're monoclonal antibodies given by injection, and they are by far the most effective non-statin LDL reducers we have.
And their target is the receptor itself.
Well, the protein that controls the receptor. PCSK9 is a protein whose normal job is to bind to an LDL receptor and basically mark it for destruction.
It puts the receptor out of service.
Exactly. So the inhibitor blocks PCSK9. By doing that, you keep more LDL receptors active on the liver surface for way longer, maximizing how much LDL gets vacuumed out of the blood.
So if they're that good, why aren't they first line?
Well, cost is a big factor, and their injections. Plus, statins have decades of data showing they reduce heart attacks and strokes. So PCSK9 inhibitors are generally for high-risk patients who can't tolerate statins or just need that extra profound LDL lowering.
Okay, we have our 6 tools. Let's talk strategy. When a patient needs help, what do the guidelines say?
Statins are always the foundation. The first decision is what intensity high versus moderate, and that is based entirely on the patient's individual risk profile from the ACC/ASHA guidelines.
And there are 4 big risk groups that automatically get a statin. Number 1, anyone who's already had a cardiovascular event, heart attack, a stroke.
For them, if they're under 75, we start with high intensity. If they're over 75, we often go with moderate intensity, just because the risk of side effects goes up.
Number 2, patients with really severe genetic high cholesterol, so an LDL over 190.
That's an automatic high-intensity statin, no question. The risk is just too high. Number 3 is diabetics, age 45 to 70. For them, we calculate their 10-year risk. If it's over 7.5%, they get high intensity. If it's below, they start on moderate.
And the last group, number 4, is the general population. Non-diabetics, aged 40 to 75, with that same calculated risk over 7.5%.
They start on moderate intensity. The common thread is we're treating the overall risk, not just a single cholesterol number.
So if a patient is on the max statin they can handle, but they're still not at their goal, how do you choose the add-on?
That's the art of it. And it comes down to which number is still high. If it's persistent high LDL, your best next choice is ezetimibe, or a PCSK9 inhibitor.
And if the main problem is still those stubbornly high triglycerides.
Then you're reaching for niacin or a fibrate. But you have to be so careful about the conflicts we talked about. You avoid fibrates in patients with kidney problems. You avoid niacin in someone with gout or uncontrolled diabetes. The choice really depends on avoiding those very specific adverse effects.
What really stands out to me is how interconnected this all is.
Yeah.
We've seen that most of our best tools, statins, ezetimibe, bile acid sequestrants, they all rely on the same core principle,
They do.
tricking the liver into upregulating its LDL receptors because it thinks its internal cholesterol is low. So
Yeah.
understanding chylomicrons and LPL and those receptors, that's the key to understanding why all 6 of these drug classes even exist.
Absolutely. They are all just, sophisticated ways of fooling the liver into ramping up its cleanup operation.
Which leaves us with a final thought for you to chew on. We focused on how drugs like bile acid sequestrants force the liver to divert its cholesterol into making bile acids, effectively tricking the cell. And while that does lower LDL, what are the implications of deliberately sidestepping the body's natural feedback loops? What does that do to other metabolic pathways we might not fully appreciate yet? There's always more going on under the surface.
That's a perfect point. We're treating one system, but the body is always holistic.
Thank you for joining us.